Thank you, Jackie. So it's my pleasure to present this month on a project that I'm really quite passionate about, and very excited to present some of the results to you today. It is still ongoing, but I have some final results, some results that are final and some that we're still working on, but you'll be the first to learn about them. So what I want to do for the first part of the presentation is just provide an overview of the whole sort of process, because this was a knowledge translation project, which may be a little bit different from what you might be used to, and then present some of the exciting results. So just to start with some background in terms of just setting the scene for this project. So we know about 2/3 of patients who are diagnosed with cancer are either current smokers, recent quitters, or have a history of smoking. And approximately 1/4 continue to smoke in the first year after diagnosis and throughout treatment. And actually, this number increases over time, suggesting that some people may quit smoking when they're first diagnosed, but then they go back to smoking after their treatment's over or during treatment. So relapse prevention interventions and programs are crucial at the time of diagnosis, but also throughout the cancer trajectory. Why it's important for people to stop smoking during their cancer diagnosis and during treatments is because we know that continued smoking in cancer patients who are undergoing different treatments have been shown to result in many negative outcomes, including decreased treatment efficacy, reduced survival. There's an increased risk for occurrence and second malignancies, obviously, big issues in terms of wound healing, and higher rates of treatment toxicities and persistent effects. And on the more positive side, we know that quitting smoking can improve people's quality of life and result in better performance status. What we also know is that many people who are first diagnosed with cancer are really motivated to quit. So it really is one of these sort of teachable moments or an opportunity to significantly impact on a person's cancer outcomes and to improve their quality of life. So it's a really important time to intervene. In terms of smoking cessation in general, we know that screening and advice on smoking cessation can actually be an effective first step to smoking cessation and increases the likelihood that a patient will attempt to quit and be successful. But in terms of the cancer setting, routine screening and provision of smoking cessation treatment has not really been widely implemented here in Canada or in the States even. There was a recent survey of ASCO members, and while 80% of these people who responded to the survey believed that smoking cessation should be part of standard of care, and they did report that they do ask their patients about their smoking status, less than half of them, though, actually offer any cessation strategies or referrals. So they're asking about it, but they're not actually doing anything about it. So ASCO and the AACR have actually come out with some statements in terms of policy around smoking cessation and referrals. So ASCO says the oncology practice should improve its systematic assessment of tobacco use and cessation to address this topic in both a time and cost-effective manner, which I think is really important to think about, and stresses that providers have the necessary tools and resources to be able to effectively offer cessation services. The American Association of Cancer Research states that all cancer patients who use tobacco or have recently quit, so in less than 30 days, should be provided with smoking cessation assistance, and that the oncology healthcare provider is responsible for ensuring that the patient receives appropriate care in this manner. And following this, CCO, so Cancer Care Ontario, here in Ontario, organized an environmental scan to determine the need for a more standardized approach to smoking cessation programs within the cancer system here in Ontario. And they subsequently developed an advisory committee which established a plan and provided guidance for the implementation of a program here in Ontario. And in the 2011 and 2015 cancer plan, Cancer Care Ontario mandated that all new cancer patients across Ontario, across our regional cancer centers, be screened for smoking status, and recent or current smokers be advised to quit and assisted with quitting. So this was something mandated in the cancer plan here in Ontario. So, and in response, I'm giving you a lot of background just to sort of tell the story. So in response to this, at Princess Margaret, in response to this mandate that CCO came out with, in 2013, we began an effort to sort of align with this mandate and improve the care and outcomes of our patients, and developed our own smoking cessation program here, with the goal that every new patient at Princess Margaret be screened for smoking status and provided with a referral or a resource. And this is sort of how it looked in the first couple of years that we rolled this out. So basically, any new patient that when they came and got checked in at their clinics were given a paper form that they were asked to fill out. They were asked on the paper form what their smoking status was, and then the responses were placed in the chart, and then the healthcare team, so the oncologists and nurses, were to be reviewing this, and if the patient was a smoker, we're then to be offering a referral to the patient and giving them information on different cessation programs, including the CAMH, which is a in-person counseling program, the Smokers Helpline, or referral to our pharmacy where they could get nicotine replacement therapy. And for those people who were not interested in smoking cessation, they were to provide a pamphlet for patients who don't want to quit, just that has some information on reasons for quitting and referral numbers if they change their mind. So that was the process. And this was implemented by site by site across the different tumor sites at Princess Margaret. And over like the first year, by July 2014, it had been, this process had been implemented across all 13 sites at Princess Margaret. And there was a really great, I think, implementation process where all the clinical teams were made aware of this new mandate, that this was an expectation that all new patients receive this paper-based screening. There were team meetings and emails that went out. All the patient flow coordinators and patient care coordinators and nurses were trained on the workflow and the process on how to do this screening. And then the smoking cessation team tracked monthly performance on screening rates and referral rates, and this was fed back to the teams and tracked by the smoking cessation team. So what they found, and the numbers, I mean, I think these were sort of rough estimates, but at the time, they then tracked the performance over the first sort of year of this implementation, and what they found was that they had fairly good uptake, but not perfect uptake. So about 55% of new patients were actually getting screened for their smoking status. This really varied widely by tumor sites. So some sites were really good at remembering to do this. Some sites were not so great at doing this, but it was an average of about half of the patients were actually getting that paper and asked about their smoking status. The rate of recent and current smokers remains steady, with about an average of 17% of new patients were recent or current smokers. What is really good news is that there's a really high interest in quitting. So we saw 60 to 70% of the patients who were actually screened indicating an interest in quitting at that time of screening, so that's great. But unfortunately, what we saw was that once that screening form was filled out and put into the chart, there was very little follow-up with the patient. So actually only 20% of the healthcare professionals actually took that paper-based screening form and talked to the patient about it and offered a referral to them, which is a little bit of a problem because we're asking, but we're not doing anything about it. So this is where I sort of came into this project, because I was in a meeting and I was looking at these numbers, and to me, I mean, obviously the screen rates, they were around 55%. They're okay, but still suboptimal. But I think what the biggest issue that really stuck out to me was the high number of people who were indicating a readiness to quit and interested in wanting to quit, and the low number who were actually being offered a referral by our clinicians here. And I think really, to me, it's just such a lost opportunity to be able to have an impact on the patient's immediate outcomes and and their long-term health. But I think it's important to acknowledge that this to me is a knowledge to practice gap, where we know that this is what we should be doing, but we're not actually doing it. But that it's probably complex, and it is complex to implement any kind of new tool or process within our really busy cancer clinics. And so we really have to be thinking in a more innovative way and a more sustainable way and a realistic way of how can we actually do this and get it done when you have clinics where they're seeing maybe 60 to 100 patients in a day. So knowledge translation and implementation science is not a new area of research, but certainly for me it's something that I'm really interested in and really passionate about, because to me it's actually really a great area of research because you get to see care really change. So, globally we know that health systems fail to implement evidence. There are many, many guidelines out there that have been developed that have never been implemented into care. The result is inefficiency, obviously, but also a reduction in both the quantity and quality of life for patients. Knowledge translation is really defined as a method for closing the gaps from knowledge to practice. And implementation research is really where you actually implement new tools or guidelines into actual clinical care. And the translation of research, as hopefully you all know, is mandated as part of CIHR and is obviously closing the loop within our research cycle. So that all leads to the current study, which is a knowledge translation study that we put in for funding and we're funded to do. Meredith, Giuliani, and I are the co-principal investigators on this. So the objective of this study was to implement and evaluate the adoption and impact of an innovative knowledge translation approach, which was called CEASE, and I'll describe that in a minute, to promote smoking cessation in cancer patients. So there were 3 aims to this study. The first was to facilitate the adoption of a patient-driven support system, decision support system called CEASE, so the smoking cessation e-referral system, to promote smoking screening as well as referral to cessation programs. The second aim was to evaluate the implementation and use of CEASE within our clinics here. And the third aim was to get a preliminary estimate of the effect of CEASE on screening, referral, and quit patterns here at Princess Margaret. So we used both quantitative and qualitative methods and data sources, and it was guided through our approach was guided by the Ottawa model of research use, which is a pretty widely used change theory and KT model. And the Ottawa model actually provides a really nice systematic and practical and what I like is a very staged approach to guide the tailoring and implementation of research knowledge or evidence into practice. And basically it includes these three stages. So the first stage is where you really just get a sense of an environmental scan, assessing what are the barriers and what are the supports or things that will help you in your implementation. Stage 2 is where you actually implement and facilitate adoption of your new innovation. And 3 is where you actually then evaluate the impact of this implementation on whatever it is, process of care outcomes or patient outcomes, whatever it is. So I'm going to go through these stages and what we did with our study. So stage 1 actually had been done before we started this study. There had been quite a bit of research that we had done and surveys that we had done here at Princess Margaret, looking at identifying enablers and barriers. So there were many enablers. So these are supports that we were able to identify, which allowed us, we were really entering a really great environment to be able to do this. So first of all, there was that CCO framework and mandate saying that we have to do this. So there's the requirement that we have to be screening and referring our patients. Secondly, at Princess Margaret, we had really great support from the leadership here at Princess Margaret for getting this done and the importance of this. And also from our clinical team. So all the clinical teams, despite the fact that they were having a hard time, doing that referral and remembering to do the things that they needed to do, they all want their patients to stop smoking. So that's certainly lots of interest there. And we saw also all that great motivation from the patients themselves with, up to 70% of them saying, I do want to quit. So those are all great enablers, and these are all people who play an important role in this model. But in terms of the barriers, I mean, obviously the time constraints are the biggest barrier. and the lack of familiarity with cessation resources. So the physicians and nurses didn't always remember, okay, where should I send people? What, you know, I don't know how to describe these cessation programs, and not necessarily knowing how to educate patients about the benefits of smoking cessation. So those were really the significant barriers to prevent widespread counseling and referrals, and just, you know, just the realities of our cancer clinics and how busy they are. So based on these findings, we adapted our approach and got rid of the paper, our paper-based model that we were using, and developed an electronic patient-driven and clinician-supported model that would allow for systematic screening and patient-initiated self-referrals to cessation programs. So basically what we were doing is cutting out the middle person, which was the clinician, and getting patients access to cessation resources that they could refer themselves directly to. So we know that this is basically a patient-mediated knowledge translation model that we did. So we know that patient-mediated interventions aim to engage, really effectively, actively engage patients to improve their knowledge, experience, service utilization, and health behaviors, and ultimately can result in improvements in health status. So I'll describe what CEASE is, and I'll just show you some screenshots of what it looks like. So it's an innovative patient-directed electronic platform that consists of 3 elements based on the CAN-ADAPT 5A cessation model, which is used, I think, model for smoking cessation in all, like just in the general population. So basically the 3 steps are first asking, so finding out what people's smoking status is, then providing them with patient education regarding the benefits of smoking cessation, so that's the advise, and then we included a simple patient-directed automatic referral system, so that's assessing and assisting in providing referrals. This was delivered, so at Princess Margaret, we have an electronic symptom distress screening system in place in all of our clinics that we already use, and patients, when they come for all their visits, they get an iPad and they're asked questions about their symptoms, their distress, their social functioning, those types of things. And that was something that was already in place here at Princess Margaret that patients were used to doing. So they just automatically come in, they get an iPad, they fill out the questions. So what we decided was to pair up with this DART system and to add our smoking cessation screening questions onto that existing platform. And that way we didn't have to develop our own separate iPads and platforms, so patients didn't have to have multiple iPads and things that they had to do. And then based on their smoking status, so they're just asked, the first question they'll ask is, are you currently a smoker, have you recently quit? And there's a tailored response. So if they have quit or they're not smokers, then they don't get any more questions and it's sort of done. But for those people who are smokers or recent quitters, then it goes deeper and provides more information to them. So I'm just going to exit this and pull up our screenshots here so you can see what it looks like. So basically, it's just the first, and we worked with our patient education team really closely here in terms of trying to get the right wording and making sure that it's the wording and the education is provided in the most effective way. So first of all, just asking if they've used products such as cigarettes, pipes, cigars, or chewing tobacco in the past 6 months, yes, no. If they say no, then it's sort of the end, but if they say yes, we ask them, we also ask them about exposure of tobacco products at home. Then there's education around why it's important to quit. So everybody would get this information on why it's important, what are the benefits of quitting. And again, with patient education team really talking about, instead of talking about the negatives, talk about the positives of quitting, like what are the benefits of quitting. And then if they wanted, they could actually find out more about the benefits of quitting. And that provides here more information just about what they would decrease their risks of, short-term and long-term benefits. Okay, and then they're asked how many years they've smoked or used tobacco products, which describes their following condition or current situation. Would they consider quitting at this time? Now, again, all of this is tailored based on their responses, so they may not see all of these screens. I'm just showing you all of the screens that we have. So if they are interested in quitting, then we talk about some of the programs that they could choose. Okay, and then there's discussion. They get a brief description of each of these smokers helpline, the nicotine dependence clinic, as well as the pharmacy, and then they can choose one of these programs that they want to refer themselves to. And we actually, I will tell you a little bit about the pilot results, but we did find that also a lot of people said, you know what, I think I could do this on my own and I don't need a program. So we added that in as an option too. So then once they've selected, it will say that someone from the program will call them and follow up with them, and an automatic referral was generated and sent out to that referral, to that program. Okay, and I think that's it. I won't show you any more here. I'll go back to my presentation now. But basically, you get a sense of what it looks like, though. And this, as I said, is all delivered on iPads. So the new workflow, it looks like this. Basically, a new patient would come to a clinic, check in. They're handed the iPad. They complete this e-tool. Their current or recent if they're current or recent smokers, it triggers this patient education, and then they are all offered a referral to a smoking cessation program if they're interested in quitting. The patient would self-refer. That's autofaxed to the agency. There's a summary then that actually still gets printed out on the printer and gets put into their file so that the healthcare professional can follow up and say, that's great, I see you've got a referral, and provide support to that. And then we actually followed up with everybody who was a recent or current smoker 1 month later and sent them a questionnaire asking them about their smoking status, and as well asking them whether they followed up with the referral, the referral program, and those types of things. So I'll show you that data in a minute. So our first aim was really, how do we get this CEASE program implemented into the clinics, and how do we get a better screening rate within the clinics? It was our big challenge. And we also wanted to look at whether we needed to refine this program and get feedback from people. So I know this looks a little busy here, but basically the first step for us was like facilitating this implementation. We used a number of different enabling and reinforcing strategies based on the awareness to adherence model of behavior change. So basically what we did was we went out, we did a little dog and pony show to all the different tumor sites, went to tumor boards and different rounds and site business meetings, and told them about the new program, gave them a demo of it. There was an email sent out from our medical director, Mary Gospodarowicz, to the whole hospital, telling them about this new system, telling them about that this is a requirement, that all new patients are screened. We also had interviews with patients, took them through the CEASE platform, got their feedback on usability, wording, those kind of things, made some changes. We developed some posters and patient education materials so people were aware that this is a new program. And figured out sort of the workflow within each of the clinics from both the patient perspective as well as the patient flow coordinator's perspective, and how we can logistically make sure that everybody's getting those iPads and filling them out. And then following the final revisions to the whole workflow, and once we had figured that all out and everybody was aware, we started to actually roll out the program. And we started with 3 disease sites where we piloted it, made any final revisions, and then we did roll it out to all of the sites. And then over several months, we actually just monitored the sites. We did audit and feedback, so we would audit how many patients completed the CEASE platform and fed that back to the teams, letting them know how they were doing, looking at whether there were further workflow issues that we needed to work out. There were many reminders sent out to the teams, and then as well the patient-mediated intervention. So this is the way it looked over October, November 2015. We piloted in head and neck, breast, and gynae. Then we rolled out in November, on November 27th, to CNS, eye, endocrine, GI, and skin. And then our final sites on January 29th were hematology, GU, lung, and sarcoma, and that was, and all of our tumor sites had been, it had been implemented. There were emails to site leads, site rounds, as I said, all users email. user information sheets were developed, so the patient flow coordinators knew the process. That was also sent to the nurses and physicians. We also developed patient flow coordinator scripts, so they understood how to introduce this to the patients, and there were posters for the patients to know that this was coming. Now, this is really small, I'm sorry, but this is just a screenshot of the audit and feedback results that would be emailed each month. So each month, the patient flow coordinators and nurse managers would get an email letting them know, thank you for your efforts in directing new patients to complete the DART and the CEASE program. And then it shows the screening, so the monthly target would always be 70%, and it would show each tumor site and how they were doing. The green means they're doing great, they're on target. Red would mean they're not on target and not improving. We don't have any oranges this month, but they would be orange if they were not on target, but it showed there was a trend towards improving. And then, you know, whenever we saw red, we would follow up with those tumor sites and talk about what happened. You know, sometimes we'd see a dramatic decrease and we'd follow up and say, what happened to your site this month? And we'd find out, oh, all the iPads, like there was some system problem or something where the iPads weren't working or those kind of things. Okay, so from October to November, we did the pilot implementation in the 3 sites. And this was really helpful, actually, because there were a lot of lessons that we learned when we were implementing in these sites. So first of all, we realized that we needed to work with, because the patient flow coordinators were the most important people in this, because they're the people that sit at the desk, and when the patient comes and checks in, they're the ones that have to remember to hand that iPad to the patient. So we had to email the patient flow coordinators, we had to meet in person with them, we had to train them, we had to talk to them about barriers, and it was lots of work working with them to try to get them to remember to do this. We also had to remind the nurses to ask the patients if they had completed their screening when they went into the room. So when they were taken into the rooms, they should have already completed the screening. So the nurses had to remember to be asking, hey, did you do your screening before they put them into the rooms? We also realized that, you know, these are busy clinics, and having volunteers could play a really important role in helping this. So where possible, we needed to get some more volunteers in place, and also more iPads, because some of the sites didn't have enough iPads to help new patients. So some of the patients needed just a little bit of help because it was their first time using the iPads because they're new patients. And so sometimes the volunteers would be really great help because they could sit down with them and just take them through it the first time and how to use it. And then there was some wording within the system so we got additional feedback from patients and clinicians on things that we needed to change. There were lots of education needs for the clinical staff. So the main barriers were like the clinic staff felt like they didn't want to overwhelm new patients. They were worried about patient burden, and they also assumed that older people wouldn't want to use iPads. They wouldn't know how to use them. So those were assumptions that weren't necessarily correct. And so we had to really address this through additional training sessions and communication with the patient flow coordinators, nurses. And the communication really was that CEASE is part of standard of care, and all new patients need to get this. And the older patient, the system is set up to be very easy to complete, but volunteers can be put in place if they feel that an older patient needs some additional help with it, or anybody. That doesn't have to be an older patient, but if a patient needs help. We added more iPads through the study grant for some of the bigger sites where they needed more iPads, and we added posters and stuff so that we could emphasize to the patients the importance of completing this tool. So this is where we get to the fun part. Then we wanted to evaluate the implementation, so what patients received this program. We looked at, and actually it's not 3 months, it was 6 months. Was the process of implementation followed as we had planned, and were patients and healthcare professionals satisfied with the implementation process? So really, this is just looking at fidelity. So, you know, are the screening rates, is this getting done the way that our process being followed the way it's supposed to be? And we also want, at the end of the study, we haven't done this yet, get reaction to from the healthcare professionals on the implementation process and how this has all turned out and what they think about it. And we're also collecting feedback on patients who received the C system on their input and feedback on using the system. And then this is the actual looking at, you know, our outcomes. So we wanted to gain a preliminary effect of the estimate of the effect of CEAS on both patient-related outcomes as well as process outcomes. So does the implementation of CEAS increase smoking screening rates? Does it increase referrals to smoking cessation resources? And does it result in increased quit attempts and smoking cessation? So what we did was we used a time series design. So basically, before we implemented CEAS and we were still using the paper-based system, we collected screening rates, referral rates, and questionnaire data on patients for 6 months pre-implementation. Then we went through the whole intervention implementation period, which was a little bit of time to implement across all the tumor sites, work doing the piloting, further revisions, and then the final, and then we did a final post-implementation cohort that started last spring, and it's just finished this past November. So I'll show you that data. So the things that we were looking at, as I said, were screening rates, interest in quitting, referrals offered, referrals generated, and in terms of outcomes, uptake of referrals or other smoking cessation programs once the referrals were generated, and quit attempts and smoking status of the patient. So this data we were already collecting, and we collected here as we monitored through our system, but we also, as I said, sent out questionnaires. So anybody who was a current smoker or recent quitter in the system got sent a questionnaire following up with them, and it was 4 weeks later we sent a questionnaire. 4 weeks after they had completed the C system, we asked them questions about, you know, did you receive, do you remember getting going through the system? Did you follow up? Did the program that you got a referral for follow up with you? Have you been in contact with them? And what's your current smoking status? And have you tried to quit? Those types of questions. Okay. So this is the process of care outcomes pre-implementation. So this is before, we implemented. This is a paper-based model from April 2015 to September 2015. So what we found at that time, this is our pre-cohort, that the overall screening rate was 44% across the different tumor sites. 17% were smokers. Of those, 73% were current smokers and 25% had recently quit in the past month. Great interest in quitting to smoke. So again, that 76% of them said, I'm interested in quitting smoking. Based on that questionnaire and on the paper, this is based on their answers on the paper-based screening. Then what we found was that only 24% of those who are current smokers and interested in quitting were actually given a referral versus, and of the people who are recent quitters, only 7% actually were given a referral. And actually the recommendation, I should talk about that for 1 minute. Even though somebody has already quit, there is the recommendation that if they're a recent quitter, there's a good chance that it could fail, or they actually need some additional support in that early time when they receive. So the recommendation is that they're still offered a referral to smoking cessation programs to help them in that quitting effort. But probably what happens is that a lot of people think, oh, they've quit, so they don't need anything, so they were really not getting any referrals. And then, you know, so 24% were getting an actual, were getting a referral. And then of those who were offered a referral, 45% said, yeah, I'll take the referral and get a referral. But so if we look here with the overall referrals recommended, so the overall number of referrals that were provided was only 19%. And it's 5.8 for all smokers. If you go back to this number here, it's only 5.8 and ended up with a referral in the end. And of those who are willing to quit, 11%. So really low percentages of those, and in the end, getting referral. Okay, so this is our post-implementation. This was from June 2016 to November 2016. All right, so our screening rates went up, which is great. We're getting a 65% screening rate. 15% were smokers. Again, same kind of distribution of current smokers and recent quitters. Same number of people who are willing and interested to quit, so it's around 76%. With the new C system, every single person who said they're interested in quitting was offered a referral through the C system. So everybody now is getting that referral offered to them. So the overall referrals now is 100%. Of those who were offered a referral, 26% said, I will take a referral, and 74% said, I want to quit, but I think I could do it on my own. So in the end, what we had was overall referrals provided to all smokers with 17% and 26% to smokers willing to quit. Okay, and this is the outcomes based on the questionnaires then. So just remembering that we sent a questionnaire out 4 weeks later and asked them to fill it out. The return rates weren't fantastic, but they were okay, I guess. I don't know the actual percentage. Mihaela, you know? Yeah, they were only like 36% return rates. But these people are currently undergoing their treatment in the first month since they've been diagnosed. So anyway, I think those return rates are okay. So what we found basically, this is about their current tobacco use 4 weeks later. So what we found is that the tobacco use rates really aren't that different between the pre and the post. So this program didn't increase the number of people who were actually smoking or not smoking. We still found that about 30% of people were currently still smoking after 4 weeks later. Some of them had reduced their, they were currently smoking, but they had reduced the amount of tobacco that they were using. 5% versus 9% said they stopped in the past 4 weeks, and 34 versus 30 had stopped more than, those were the people that had already stopped before they got the CEASE platform. And around 40% said that they've made an attempt to quit smoking over the past month. But where we did see lots of really big differences was when we asked them, so first of all, at your first visit to Princess Margaret, did you receive information on tobacco use and its influence on cancer treatment? So 35% said yes in the pre-cohort, 54% said yes in the post, which is kind of surprising because they all had, but a lot of them said, I don't remember. At your first visit to Princess Margaret, were you offered any referral to support? So 24% in the pre said yes versus 71% in the post. If you received a referral, have you been in contact or has the referral followed up with you? So only 4%, even though there was a lot of people who in the pre-cohort said that, you know, there was 45% who were offered a referral and accepted it. Only 4% of them actually had any follow-up with the referral source. So I don't know if that's because then the healthcare professional never sent in the referral or what happened in that. Again, I lost sort of, something got dropped there. I don't know what happened. But what we saw, which was great in ours, is that almost 63% of those people who generated a referral then had follow-up contact with the referral program. So that those referrals are going through and something's happening. And then, did you feel the information referral you received helped you make an attempt to quit smoking? 12% in the pre and 30% in the post. So just to summarize, CEASE was fully implemented across all tumor sites at Princess Margaret. The screening rates increased from 44% to 65%. The referral rates increased from 19% to 100%. The accepted referrals for current smokers increased from 11 to 26%. The accepted number of referrals was higher, so we saw that if the healthcare professional offered a referral, 45% said, yes, I'll take it, whereas in our program, only 25% accepted a referral when it was offered through the CEASE platform. I think we can think about this a little bit, though, because I think that maybe sometimes patients felt like they didn't want to say no to their healthcare provider when the referral was offered. But also, or maybe they did want to take it, but then we saw that only 4% of them actually followed up with the referral program afterwards. So something happened there where the referral got dropped. So that And then we did see the proportion of those still smoking was similar between the two cohorts at 4 weeks. However, I think there's two things that we can think about. So we know at least this platform reaches far more people. So just in terms of the volumes of patients, there's more people getting offered these referrals and the volumes. So more people are getting offered these referrals and getting information. So I think that's great. We're reaching many more people. I think the other thing is that if we think about that 4-week timeline, I think 4 weeks might be a little bit too short to expect that people may have already quit. So I think maybe if we were to follow up again 3 months later or something, we might see some more difference, because it could be just in that 4 weeks, they've just sort of made that contact with the referral with the smoking cessation program, but they haven't really started their program or gotten underway with it. But I think certainly, this highlights this is a challenge to develop effective smoking cessation programs. Even when you get people into smoking cessation programs, the fail rate is very high, and so that continues to be a challenge for cancer patients and all people who want to quit smoking, and for the smoking cessation programs that are being developed. So in terms of next steps, we are continuing to just collect data from questionnaires, but also we are doing we'll be doing some interviews with the healthcare teams here at Princess Margaret to get their feedback, and getting the qualitative feedback from patients through the questionnaires. That should be all done by February, March of this year. The great news is that there's lots of interest in the CEASE platform, and so there's 2 hospitals here in Toronto, Sunnybrook and St. Mike's, who are interested in expanding and adopting our CEASE platform to their centers. And as well, there's a couple of clinics within University Health Network here, for example, the lung screening program, that want to put CEASE into their clinics as well. So there's lots of great interest in adopting this platform. Another thing we learned too is that we originally had designed this to be a screen just for new patients right when they were first diagnosed, but then we thought it would be important to follow up with people over time. And so we've now implemented a 6-month repeat screen. So 6 months later, they'll be asked about their smoking status again. We know because people do end up relapsing, and so we want to make sure that if they do relapse, that we can offer services again to them. And hopefully what we'll do is we'll add a 12 months later on. Right now we're testing out the 6 months. So that's that, and I'm happy to answer any questions that you might have.